Hi guys, I hope you guys are doing good. So I want us guys to talk about so we cannot finish this topic of hypertension without talking about hypertensive crisis. Hypertensive crisis. So what is hypertensive crisis? Hypertensive crisis is a crisis. So if you've got a patient that's got a blood pressure that is more than 180 over 120. Once you get someone who's got a blood pressure of that magnitude, and the next thing that needs to be done is to assess them for a target organ damage, so that you can classify them according to that. So you need to decide according to that, to the presence of target organ damage or TOD, whether they are hypertensive, emergency, or whether they are hypertensive urgency. So hypertensive, so the common thing about these patients is that they've got a blood pressure that is more than 180 over 120. So here there is target organ damage, but here there is no target organ damage. That's the difference. We get a lot of these patients who has got a high blood pressure, but most of the times we tend to focus on dropping the blood pressure and not really looking for a TOD. So which is something that we really need to improve on. So guys, another observation that I've made, when someone has got a high blood pressure, we get a lot of patients who have got high blood pressures of 170 something, or 115, 105, things like that. We get a lot of those patients. And yeah, so one other thing that I've observed is that there are patients who would come in with a high systolic, maybe 171 over diastolic of 91, or even in the 80s. These patients are not started on treatment, and it shouldn't be happening like that. Remember the definition of hypertension. A blood pressure, it says it's a blood pressure of more than 140, or a blood pressure of more than systolic of more than 140, and or a diastolic of more than 90. So which means you can have an isolated systolic pressure being high and you can still diagnose your hypertension, or you can have an isolated diastolic being high in the presence of a normal systolic. That's still hypertension. So those patients should be treated. Obviously you will do the blood pressure testing the way it's supposed to be done, over hours, over weeks, things like that. But if you get, because you can get a patient who's got a predominantly high diastolic or a predominantly high systolic, so those patients are still hypertensive. That's just what I wanted to talk about. So when you talk of TOD, what are we talking about? So here is just a blood pressure that is more than 180 over 120. That's it, no TOD. But here there is TOD. So what is TOD? Okay, so TOD, we talk about the eyes. So this guy, to assess for the eyes, you do a direct, which we don't always do, fundoscopy. So here you check for for cotton wool like spots. You check for papilledema. You check for hemorrhages. You check for exudates. So basically, this is hypertensive retinopathy. Then the next thing that should be done is the heart. Okay, let's check the brain first. With the brain, you can either have hypertensive encephalopathy, or you can have neurological signs already. Hypertensive encephalopathy, patient with headache, dizziness, they might have confusion, they might have low GCS. Patient with neurological signs, hemorrhagic CVA with focal signs. Right? That's our brain. So then we go to the heart. With the heart, the patient can have an MI. They can have acute coronary syndrome. MI or acute coronary syndrome. Remember, MI is part of acute coronary syndrome, which means they can have STEMI or non-STEMI or an unstable angina, basically. They might have go and check our video on approach to chest pain where I talk about this in detail. So they might have left ventricular hypertrophy. They might have and then when it comes to the lungs, they might have pulmonary edema, which will present in shortness of breath, crackles, dropping in sets, chest pain, wheezing. They might have wheezing, all of that. So, and then the kidney. Quickest way to assess if the patient has got hypertensive nephropathy, dipstick. There you check for hematuria. You check for proteinuria, and then you can also do urine for albumin creatinine ratio, and also you can check for aortic dissection. You can do a chest x-ray here to check for a widening the mediastinum, if you can pick it up. So that's your hypertensive vasculopathy. Another thing is check for PVD, peripheral vascular disease, as well. Hypertension is a very big risk of peripheral vascular disease, together with smoking and diabetes and all of that. So so this is 1, this is 2, this is 3, this is 4, this is 5, this is 6, this is 7. So guys, if you are doing exams and they talk about hypertension, they will talk about hypertensive crisis, I can promise you. So you need to know what to look for, what organ, what features, and how do you test for that. So basically here you will need for heart, you will need a chest x-ray plus an ECG You might want to also do BNP or pro BNP. You might also want to do your TROPS, especially if they've got a chest pain, CKMB, those are the bloods. So this is how you can evaluate your heart. Then based on your ECG, then you can be able to pick it up if they've got an M mitrale, if they've got an ST elevation, whatever. And then here you will depend mostly on the clinical. You can send them for a CT to check if they've got a stroke, CT brain, to check if they've got a hemorrhagic stroke or a ischemic stroke. For PVD, you can send them for a CT angel to check if where is the obstruction. So even a CT angel for a aortic dissection, you can also pick that up on a CT angel. Basically this is this. So in terms of the management, I'm gonna be general here, guys, no? But what I can tell you now, in terms of the management, these patients, they need their blood pressure to be dropped in minutes, which means you need IV drugs here. Here, you need to drop it over 24 to 48 hours. So which patients can present with hypertensive crisis? So it's someone, so there are patients who can present with hypertensive crisis for the very first time. They're not hypertensive, they just come in with hypertensive crisis, not never been treated before. Or it can be someone who doesn't adhere to the treatment, no compliance, or to the diet. Or it can be someone who has been taking the treatment well, but for some reason they've eaten a lot of salty food, so they come in with a high blood pressure like that. I think also even someone who comes in with a secondary cause of hypertension. Remember, you can have essential hypertension, which is primary hypertension, and develop a secondary cause again on top. It becomes superimposed. So it can be someone like that too.